Hi you guys, we're continuing on cardio. This is the second video. This is just a reminder of this slide on flow. So what we were talking about in flow is that if you do something like double the radius of a vessel, the flow is not going to be simply doubled. It's going to go up 16 times. And why is that? It's because the formula has radius raised to the fourth power. So that's where we had stopped. And here's the formula. And this is just a physics formula, Pathophysiology equation for fluids, for any fluid. We're going to use it for the body. That says that a flow is equal to pi times r to the fourth times delta p divided by 8 times length times viscosity. So what we hadn't looked at is this part of the equation. That is never going to change. It's pi over 8, and it's going to stay that way. So you know that pressure and radius are going to be directly proportional to flow. The greater the radius, the greater the flow. And the greater the pressure, the greater the flow. What diminishes that flow then is what is in the denominator of this equation, and it's the length. Remember the length of the straw that we were talking about, and the viscosity. If blood all of a sudden becomes very thick, then flow is going to diminish. So above here we're talking about directly proportional, and below the line we're talking about inversely proportional. So length is inversely proportional to flow. Pi over 8 is never going to change, so I'm just going to leave that there for you. Really, when we're thinking about the body, we're thinking of the radius of an artery, the pressure of the blood, the length of that vessel, and the viscosity of the blood. Blood flow is dependent on pressure changes and resistance, correct? So pressure and resistance are opposing forces. And the total peripheral resistance is the sum of all those vascular resistances. Why are we thinking about all this? We're thinking about all this because, for example, atherosclerosis. In atherosclerosis, you're going to have the narrowing of the arteries. You're going to have cholesterol accumulating inside those arteries. Those arteries are going to narrow. If they're narrowing, does it or does it not make sense that you're increasing the total peripheral resistance? And what's going to happen is in order to overcome that, pressure is going to have to go up. Hence the individual with atherosclerosis with high blood pressure, correct? Now, under regular situations, arteries and arterioles produce resistance, right? They produce resistance by vasoconstriction. Vasoconstriction, remember, is happening when you're closing a set of arteries, allowing less flow through those arteries, and allowing more flow of blood somewhere else. So just imagine you go out running, now you need greater flow to the muscles in your legs and less flow, for example, to your gastrointestinal system. So you will vasoconstrict digestive arteries, and you will vasodilate those that are in the muscles. So it is a way of moving your 5 liters of blood to where it's most needed at any one time. A short anatomy review on the heart follows, just to make sure that you remember all the valves, because it's going to matter. You have to understand how blood is moving through these. So let's remember the atrioventricular valves. If they're atrioventricular, it means they're going from the atrium to the ventricle. And when these are opened, it means that the ventricle is relaxed. If you relax the ventricle, blood is coming in through the atria down into the ventricle. So the actual pressure here in this picture, the pressure of this blood here is going to open the valve. So it's going to open it and blood is going to trickle down into the ventricle. Okay, so I'm telling you here, atrial blood pressure opens these valves. Now, this blood has dropped down into the ventricle, and now it needs to eject out, whether it's going here to the lung or on the left side of the heart to the rest of the body. When the pressure increases in the ventricle, it means that this is contracting, correct? I have some contraction going on here. I'm going to contract the ventricle, and I do not want blood to shoot right back up here again. That wouldn't make any sense. So what you want to do is shut this. So when the ventricle contracts, ventricular blood pressure closes those atrioventricular valves, and it can no longer backtrack, and blood is now instead going to shoot out in this direction or out of the aorta. Okay, so this is a picture of that valve: opened as the ventricle fills, closed as the ventricle is ready to eject, or is already beginning to eject. What about the semilunar valves? The semilunar valves are those that are placed at the base of these major arteries. Which ones? Well, here is the pulmonary trunk, and out goes blood over to the lung, correct? Over to the lung. And there is one semilunar valve. Base of the big vessels. What's the other vessel? The aorta. So right here is another atrioventricular valve. So now we're ejecting blood out of the ventricles. We squeeze that blood coming out of the ventricles, and the pressure of that blood is going to force open these semilunar valves. And blood will shoot out in the direction that it needs to go, either to the lung or we'll make a B here for the body. What happens once that ejection is over? Again, you do not want this blood to come back down where it came from. I'm going to put an X through that. You do not want that to happen. So you have to close that valve. So once this is ejected, in order to prevent backflow into the ventricle, my valve closes right there. And the other valve closes right here. So this is the pulmonary semilunar and aortic semilunar. This is a very good picture here because it shows that when opened, that blood pressure will shoot past that valve. Ventricular blood pressure opens the valve. However, when the contraction is over, the arterial blood pressure here closes the valve, preventing the leakage back where it came from. Remember, you don't want any of that blood to be backtracking in the heart. It would make the heart work so much harder. So these are the semilunar valves. Semilunar because they look like a half moon. This is the cusp that is filling. I think of them as teacups. These teacups are filling up with that blood, not allowing it to return back into the ventricle. Sounds. What do we hear, right? If we get a stethoscope and listen, and you're listening to the lub-dub, 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 what is it that you're actually hearing? Well, think a little bit about how fluid flows. So if you have smooth blood flow, it's very quiet. It's like a river. A river is very quiet if it's flowing smoothly. If, however, you put obstacles in the way, like a bunch of rocks on the side of the river, you're going to hear a lot of turbulence, and it's not going to be smooth flow. Disturbed blood flow makes a whooshing sound. So the first heart sound is when the atrioventricular valves are going to close, and that's the lub. So atrioventricular valve closes, what happens? The blood that's in the ventricle attempts to shoot back into the atria, and it cannot. And so what does it do? It hits the wall, which is a closed valve, and it creates turbulence, and you hear that. You hear the turbulence that is caused by blood crashing against this closed valve. So that would be the lub, the first set of heart sounds. The second one that you hear is when the semilunar valves close. So they are ejecting blood, they try and crash back, they get a semilunar closed valve and you hear this turbulence, and that's the dub. So lub-dub, lub-dub, it's happening simultaneously in the right side of the heart and in the left side of the heart. Now, this sometimes doesn't work perfectly. Sometimes some of the blood does get past the valve. So this is what a murmur is. Abnormal blood flow can produce additional sounds. What kind of abnormal blood flow? It's sneaking past the valve. So if it sneaks past the valve by some defect, then you're going to hear the lub-dub, lub-dub, but you're also going to hear some swooshing of blood going through the valve. That's kind of a sound that only after you've heard it one time can you recognize it. So in your careers, you'll probably go on and actually hear it at some point. And once you hear it once, you recognize that that sound shouldn't be there. It should just be the lub-dub, lub-dub. So this happens, these abnormalities, defects that come from scarring of that valve if it's been damaged. A classic example is rheumatic fever causes a damage in the valve, and then it heals, but still doesn't heal perfectly. So this is a normal valve that looks entire here. And on this side, you notice how it's diminished, and some blood will be able to make it past back into the atria there, and you would hear that murmur. Now let's move on to types of heart cells. When you look at under the microscope, you did this in anatomy, and you look at heart cells, you're looking at myocardial contractile cells. It's the cell that has to do one thing very well. It has to be able to contract, because if you can't contract when you're a heart cell, then the heart's not going to beat. So that's a disaster. So 99% of the cells in your heart are called myocardial contractile cells, and they do exactly that. They contract. And they contract for 94 years, however many you want or can have. The other 1% have to do with something very different. They have to do with a conducting system. It's an electrical conductance system. And those are called autorhythmic cells. They have their own rhythm and automaticity in which they're going to create the contraction. Those are called pacemaker cells. They conduct action potentials through the heart, because you know that you don't need a section of the brain dictating, delivering that neurotransmitter, telling the heart to beat. No, the heart has its own capability of originating that action potential within the heart itself. But it's on very specific cells that do this. And those are the autorhythmic cells, or the pacemaker cells. They are situated in very important locations. Where would you put them if you were making this? I always, in anatomy, when I talk about that, I always say, how would you build this? And that's what I'm thinking here. You would put some in the atria, because that's where you're beginning the contraction of the heart. You contract the atria and then the ventricle, and the atria and then the ventricles. So you would put them there. So there is one first area here called the SA node, which means that there are lots of those autorhythmic cells sitting there in that node. And from there, that action potential is going to start, but it must radiate. And if it must radiate, it needs to have a path by which it can do so. So this path is a pathway of those cells that are arranged in such a way that they will move over to the left side of the heart and towards the ventricles. When it leaves the atria, it actually hits a second blob of these pacemaker cells, and that is called the AV node. So AV node is a second blob, a group of those cells that are going to be struck by that action potential, and they themselves are going to help radiate that action potential towards the tip of the heart here. So they've given names to every single section of this. So we start with the SA node to the AV node. I'm just going to skip the other one. So 1 and 2 to the AV node. And then it comes down the center of the heart here. So we have AV bundle. But then notice this is just one piece, but here it branches. So once it branches, I have the bundle branches. That's 4. And finally, in the apex of the heart, it will come back up the sides so that that action potential can really radiate through the entire ventricle and deliver an action potential and cause a contraction, correct? And so those last ones are the Purkinje fibers. And that is the pathway. Atria to both, to the AV node, down here, up the sides, and now all of the heart is depolarized, and in that order of depolarization, it will contract. First in the atria, and then in the ventricles. Very important also that it does it from the apex up, meaning that it's going to have to contract from low here to high. And that makes total sense because the exit way for the blood is coming out of here and here, and it's those exit ways up at the top. So if we were to just contract here, we would jam blood down to the apex. Instead, we contract at the apex and shunt blood up. Those are the autorhythmic cells. What do they look like? Well, they look similar to contractile cells, but they're smaller, and they contain very few contractile fibers. So they don't really do a good job of contracting, but they do a good job of stimulating action potentials. What's that pacemaker function? If you were to be able to look at those cells that are part of the SA node and look at the rhythm at frequency at which they fire, you would notice that they fire at a frequency of creating about 70 to 80 beats per minute. So that's how many action potentials they would deliver and cause a contraction. The AV node would follow that. It will follow that and do 70 to 80, unless you remove the SA node and it wasn't there, and then the AV node on its own would be capable of initiating action potentials at about 50 beats per minute only, creating a contraction of about 50 beats per minute. And if you were to damage this and that would not be there, then the Purkinje fibers would have to take over, and they would be able to do it at about 30 beats per minute. So I'm going to go back a slide. So what happens is that Purkinje fibers and AV node, all these follow the leader. Who's the leader? The SA node is the leader. Okay, and as long as the SA node is functioning, all these will fall into place, and they will follow along at that rhythm, which is the sinus rhythm. What would happen if all of them started to fire at their own frequencies, at 70 or at 50 or at 30? What would happen? What would happen is the heart would start fibrillating. That's what fibrillation is, when all these action potentials start firing at a different time and there is no rhythm. And if there is no rhythm, the defibrillator is going to shock it back into the rhythm of 70 or 80 and set it straight again. Action potentials in autorhythmic cells, that action potential is not the same as in skeletal muscle. And I'm going to show you on the next video what that action potential looks like. In the meantime, think about what an action potential looks like in muscle, right? We had that depolarization and repolarization and hyperpolarization, and we drew that, and you knew it pretty well. So what I'm going to do now, on the next video, is show you how that can be different that depolarization is different when you're talking about the heart. Okay, let's stop this now. Thanks.